I'd like now to introduce you to the lead author of the article we're discussing today, and that's Terry Zabrowski. Thank you, Terry, very much for joining us today. As I mentioned, we're hosting this event to identify the everyday practical applications of research findings in a published article, and also to give you a sense of the research process itself. As we mentioned, today's featured article is centralized versus decentralized nursing stations, the effect on nurses' functional use of space and the work environment. Dr. Zabrowski was a registered nurse in Canada prior to obtaining her PhD in interior design from the University of Minnesota. She's worked as an interior designer, a medical equipment planner, and medical space planner, as well as directing healthcare design research projects the past 20 years. She's an adjunct professor at the University of Minnesota, teaching an interdisciplinary class titled Creating Optimal Healing Environments. On today's call, we'll have an active discussion about different key factors in Terry's study. We ask you to pose questions throughout the call today, and we'll take time to answer them at the end. So please, everyone, be sure to join in today's discussion. Let's get started by just reviewing at the beginning just what the study was about and why it was done. And I think it's clear probably to many of you that the question of how unit design, in particular some form of more decentralized nursing stations, affects nurses and quality of care has been a critical design issue for a number of years. For many, decentralized nursing units are considered best practice because of their presumed benefits: less nurse fatigue, more time at the patient bedside, increased communication and collaboration. Yet the fact is that relatively few empirical studies have been done to test these assumptions. This study was one of the first to examine decentralized nursing units. And I think, therefore, that it's an important building block in our understanding of nursing unit design. So, Terry, maybe you could help by letting us understand why you chose this particular topic for study.
Well, hi, Frank. I hope everybody can hear me. Can you hear me? Yes? Okay, thanks. Just wanted to make sure. Frank, before I start, I just want to say a few things. I want to thank the Center for featuring our article today. I want to thank very much the co-authors and the co-researchers, but specifically I want to thank Lou Bunker-Helnick, who was very instrumental in getting this published, this article, so it could be in your hands and be reviewed today. I also want to thank acknowledge John Buggy, who was the office lead for Ellery Beckett at the time this article was conceived of, about 7 years ago, and also Christine Barber, who at the time was the director of workplace at Knoll. They both are with Gensler now, but both Ellery Beckett and Knoll, through those two individuals, helped fund this project fully. And I just want to say one other thing, Frank. I know we had a bit of trouble in the technology aspect when we were practicing, so I was able to pull you up here. Just in case we couldn't get you connected, I had a picture of you ready to go today. But back to our discussion today. Yes. Really, this study, I undertook this study for two reasons. First, I'm a former registered nurse, and as such, I really understand the impact the built environment has on nurses' day-to-day work environment and how that translates into patient care. And secondly, the study was conceived of about 7 years ago. At the time, there were studies about patients and the outcomes of design on patients, but really none or very few looking at the impact of the designed environment on nurses and then how that impacted patient care. So, we really felt strongly that we needed to try to start to understand what this concept of decentralized nursing was and what it meant for both nurses and what it meant to designers in the built environment.
That's great. I mean, it's important to understand the context of why you're doing this kind of research. Could you talk a little bit about who was on your research team and the kind of expertise and experience they brought to the research?
Yes, absolutely. At the time, the other PI was Agneta Morelli. She was a registered nurse as well as a graduate student at the time in environmental psychology. And it seemed like a really great fit to have her on our team. We also had Christine Barber, who was the director for many years of workplace research at Knoll, and so workplace and work environment fit was really the theme. And it seemed like a really good fit and a really good time to start to look at that kind of environment.
Great, thanks. Let's look at what you were trying to do, the objectives. Essentially, again, you were comparing more centralized with more decentralized nursing units, and you focused on nurses and the kinds of activities nurses did in different parts of the nursing unit, the visibility of patient rooms from nursing stations, how noise levels varied, and nurses' perception of their work environment. Looking back, do you still think these were the most appropriate questions to help us begin to understand the effects of centralized and decentralized nursing unit design? Are there any other questions that at this point, looking back, you wish you could have addressed?
I think at the time we posed a really good set of questions, and we really viewed this study as really exploratory. So we had a lot of questions initially that we weren't even sure we could address in the study. For example, were nurses even able to really express to us what their experience of their work environment fit was, or how that impacted what they did on a day-to-day basis. We knew a little bit about how they spent their time overall, thanks to some studies that were done early on by Ann Hendricks, but we weren't really sure if that meant that this would change on different unit types or when we had nurses positioned at different places on the unit. So it was really a true study of inquiry.
Great. Let's look at the method. Again, part of the purpose of these journal club sessions is to sort of take apart the methodological process and look at what was done and why it was done. One of the things your study did, which a lot of studies don't do, was use multiple methods to explore your research questions. Those included direct observations of what nurses do over the course of the day, measurements of noise, analysis of photographs of the unit design, and a survey and focus groups. Why did you decide to use this particular multi-method research approach?
Well, we really wanted to explore, and so we thought because so little was really known and documented, perhaps documented more than known, we thought a multiple method approach would be the best. We had some knowledge that a relationship had existed between nurses and their work environments, but we were sure that it would be complex and layered. Work environments alone, if you're just studying those, are very complicated. And when you add into the mix the world of healthcare, healthcare design, and nurses caregiving, it started to feel like there would be a lot of pieces that if we didn't approach it from different angles, we would not be able to capture the data that we wanted. So by looking at a multiple method approach, we looked at a quantitative approach which could tell us about magnitude and frequency of occurrences, of things happening, of things that we reported or things that we asked them. But by adding the qualitative component to it, which was open-ended survey questions, focus groups, and in the end drawings, we were able to capture, I believe, more of the meaning and understanding of the concept of decentralized versus centralized nursing.
Yeah, that's great. And I myself think that's very important to look at these things from a variety of angles to be able to get a broader picture of what's going on. Let's look at the actual data collection, the methods that you used. You collected data on 2 nursing units in each of 3 hospitals. And in each hospital, one of the nursing units was more centralized and the other was more decentralized. How did you choose those particular hospitals and units?
Well, we grappled with that for a while at first, but then we enlisted the help of a research assistant who literally went through the American Hospital Association listing of hospitals across the United States, looking at sizes and characteristics that we had singled out. For example, we had looked at characteristics of a hospital that it be no larger than 400 to 500 beds, that the units that we wanted to look at would be more medical surgical in nature. We did not want to look at any intensive care, critical care areas, anything unusual like an emergency department where the ratios might be different and the kinds of acuity be different. And so we literally had her phone all of the hospitals, and in essence we actually had 5 hospitals agree. And each of those 5 hospitals had both what they called a centralized nursing station, which means that the nurses gathered in one room. to chart and to communicate, versus a decentralized, which was the nurses were in other areas along the unit, whether that, most of them were at the bedside or just outside the patient room. But at the time, even the notion of what decentralized nursing was very, it existed on a continuum. There was no real pure sense of what the decentralized nursing was. So we tried to gather those sites based on all of the units having been opened at least a year, so to try and sorry, I've lost my train of thought. Oh, sorry, to try and not have any of the newness of the environment enter into it. So we had her call anonymously and ask if they would be interested in being a study, and we actually had 5 hospitals in total. We actually had 6. 2 became a pilot study, 1 backed out at the end, and then we ended up with 5. In total, 2 as pilot and 3 hospital sites that we used to gain the research article from.
Great, thanks. Just to stick a little bit with the issue of the selection of the different kinds of units and decentralized and more centralized units. One of the issues that researchers face and people also interpreting the research is whether or not the kinds of things that you're studying, the different unit types, are comparable. In other words, if there are 3 different types of decentralized units, the difficulty in interpreting whether or not those are having an effect is quite different based on the individual variations within the kinds of decentralized or decentralized units. So to be able to compare results across different hospitals and units, which is part of what you did and what you want to do, you need to define clearly and explicitly the types of units you were comparing. Basically, one of the concerns that I had looking at this, and one of the questions I had, was how you dealt with the fact that you had not just decentralized versus centralized, but you had different forms of decentralized units that were trying to be understood in the context, as you said earlier, of a very complex kind of hospital situation. What challenge or difficulties are you facing then in trying to define the different units and trying then to draw some comparisons from these different kinds of units?
Well, it was a challenge. First of all, remember the study was originally written, the study design was written 7 years ago, and at that time we knew that because private rooms were being mandated in hospital design, we knew that units were getting larger and longer and that nurses could no longer sufficiently work from one room. So there was this notion of decentralized nursing going on across the country, but there really was no clear definition of what it was. So part of our study was to try and understand some concepts of it, and I think one of the most revealing statements we had from one of the nurses when we were asking nurses what that meant to them, the nurse said to us, decentralized from what? What are we decentralized from? So that was a very telling comment and speaks a little bit about the culture of nursing overall as well. So it was very challenging. We certainly were never able to, what I might call, operationalize the term decentralized nursing. In other words, operationalizing in research means that you're trying to find clear metrics that you can measure to base a construct or a concept on. And at the time, it just did not exist. So that's why we really had to identify this study as an exploratory study, because we were still really seeking meaning and understanding of the concepts at hand.
Yeah, it's very good. It's a very important point. Again, I've done also research on centralized, decentralized nursing units. And what's missing, I think, not just from your study, but from mine and most others at this point, is a clear typology of nursing units. And it's difficult to compare, I think, as you're saying, across units when we don't have clear operational definitions of what those are. And so that's just something that probably needs to be done in the future. Let's move on to the kinds of observations that you did. And one of the things I think, again, that is particularly important and valuable about your research is that you did direct observations. You didn't rely just on a survey or just on interviews. And you did what you called both place-centered and person-centered observations. For both, there was a total of about 3 hours for each unit, and those sessions were done in 20-minute sessions. And the observations, as you say in your paper, were done with a digital timer and paper data charts on which one graduate student who did the observations recorded the activities of nurses, where they occurred, and the time involved. How did you determine how much time would be devoted to the observations in total and per each session? I want to give the participants a sense again of your thinking as you were developing this exploratory study.
Well, because we didn't really have a clear definition of what a decentralized unit was at the time, we decided that we needed to do two kinds of observations, behavioral observations. One would be place-centered, which is that the researcher stood at one point in time and watched a place and recorded the activities that happened in tandem. I mean, not in tandem, but at the same time. So she was trying to record all of the activities and understand what was going on at a central station. But because we didn't really have in any one unit a particular decentralized station in all of the units, she did person-centered observations for more of the decentralized units. So that means that she followed the nurses around and she recorded the observations that she was observing. We used a chart that we felt covered most of the activities that could happen in a day for the nurses. It ended up collapsing some of the variables in the end. But in terms of how we decided how much time to spend, what we were trying to seek was a representative sample of each shift. So what we did at that time made sense. We also didn't want to be too invasive. Remember again that there were not many studies that preceded ours. So when we went in to work with the institutional review boards or the committees that oversee research that goes on in any kind of an academic medical center, we had to address what we were trying to do, and most, if not all of them, had never had any social science research done in their units. So it was all new for everybody. So we tried to keep the observations to be as unintrusive as possible. For example, the researcher did not go in the patient room. So we assumed direct patient care when she went in there, but we could not clarify that. That became simply too intrusive for many of the IRBs, and so we pulled that out and just had her watch them walk into a room and then come out. One thing I want to say that is anecdotal to this, but remembering the first two hospitals that we did the observations on were our pilot studies, so they did not count towards the total that was in the representative sample that we have in the article. But I remember the researcher calling me after the first series of observations that she had done, and we had decided that through the IRB staff that we would tell the staff we were there to study nurses and how they interacted with their built environment and their nursing stations. And she said that she had more of the nurses following her around, trying to talk with her and give her notes that they had made about how to change the design of the environment to meet their needs. And we realized after that we had to tell the nurses we were there for another reason, because it would confound our study. But we were so happy that had happened, because it told us that nurses could talk and could tell us about what that meant to them, about what that meant to their patient care. We were grateful for that.
That's great. I want to stay with the observations just for another moment, because I do think that they're particularly important. And as we said, they provide a different picture of how space is being used and do surveys and other kinds of data collection. In my own experience doing observations, and we've done a lot of observations in the same kind of context that you've been doing them, one of the things that we find is that tasks are happening all the time at the same time, and in such rapid succession that it's difficult to record accurately all that's going on. could you talk a little bit about the way in which you dealt with that? Because I think in terms of doing observations, it's very important to do them, but it's not simple, particularly doing it in real time with nurses who are doing lots of things at the same time, multitasking. How did you deal with the fact that all these activities are occurring in rapid succession? You're trying to record them, and there's only one person recording them. How did you deal with that, and what did you think were some of the challenges and implications of doing it the way that you did do it?
That's a good question. We also thought or knew to some degree that nurses would be multitaskers. So we tried to create a form that could easily capture that. We really had no idea how much so they were multitaskers and the kinds of range of activities that they do, everywhere from nutrition to counseling to grief counseling, I mean, above and beyond what their normal tasks are. So it was very difficult at times to keep track of everything that was happening at once. And I would say that our study, and some of you may find this hard to believe, but our study was done before iPads were created. And so we didn't have that luxury of iPads, and RFIDs, while they were in existence, were a little cost prohibitive. So we relied on pen and paper and a timer, but I have to tell you that if I had to do it again, I would definitely use videos if possible, and then that way you can get an inter-rate reliability higher because you could have more than one person viewing the video and making the observations as they count.
Yeah. Again, thank you for that, Terry. I mean, I think one of the things that we're trying to get across is that, you know, there's lots of factors that you have to take into account in doing research that make it difficult and often simply aren't feasible, whether it's because of resources on your side, on the nurse's side, staff, time, your time, cost, and so on. And so that's a characteristic of all research that's done. And part of the challenge for those looking at it is taking these kinds of factors into consideration and looking at what they mean in terms of interpreting the data. And we'll get to that in a few minutes. One of the things you also did was collected data on the visibility of patient rooms from the nursing stations. This is one of the rationales that's often given for decentralized nursing units, that it allows the nurse to observe, to help prevent falls, to see things that might happen and to intervene if necessary before they happen. You also collected data on sound levels, as well as using, again, the survey to assess nurses' perception of their working environment. And then something that I know you'll talk about in a few minutes, which was very important, as it turned out, were focus groups exploring how the unit design affected everything from the nurse's sense of professional status and their overall health to communication and workflow. So you have all these layers and levels of data collection. Of the several methods you use, which again take time, take resources, are not simple to do in many cases, looking back, do you think there were one or two of those methods that provided you particularly useful information and insight, and that others perhaps were useful, but given limited time and resources, you might not use in the future? The reason I'm asking this question in part is because much of the evidence-based design movement and the discussion in it is about increasing scientific rigor and trying to make things as often as quantitative as possible. And yet you use, again, a combination of quantitative and qualitative measures, which again I think is terrific. And I think it'd be great for you to share with the audience what you in the end found to be some of the most useful data collection approaches for giving you the kind of insights that would allow you to translate the data that you collected into decisions and making more informed decisions about planning.
Well, I think all the methods that we used were fruitful to some degree. We certainly were, I suppose, most disappointed with the questionnaire return rate, and that we could not really use we did not have a big enough sample to really make that as effective as we wanted to. But really, everything that we collected really added to our overall understanding of the phenomena that we studied. Again, it was really an exploratory study to find out if we could understand more about what that relationship was, the work environment fit between the environment and the nurses. And at the same time, we were also trying to test the use of some of these different methods in looking at our research questions. And I say it in a test because I really think that it is going to be hard for us as design researchers to always be able to quantify everything, because the experience of design is just that. It's an experience, it's a kinetic experience, and I think that we sometimes have to we will have to rely on other methods to be able to really capture meaning and understanding of design, and that's really important as you think about issues of design, of culture, and symbolism. So I really think that we have to think about that, and in part this research study that we had the privilege to pull together, really we were able to look at the different methods. And I have to say that I had not done as much qualitative research up to that point, but after doing the focus groups, I have to tell you I'm a forever fan of focus groups. While somewhat time-consuming and costly, they clearly provided the richest data for our consideration. It was incredible to go around the U.S. and have nurses talk to us about this concept of what this meant to them, of what their work environment meant to them, and how they were able to relate that to their patient care. And remember, 7 years ago, it was not that common that nurses were around the table when we were talking about design and designing. So we weren't really even sure if they were going to be able to give us much information or what they would actually say. And I have to tell you another anecdote that, from the research study. One of our very first, or the very first group that we went to visit, we brought coffee and donuts, of course. And we were at change of shift from night to days. We were trying to capture people either coming to or coming from. And we traveled quite a distance, the researcher and I, and we were sitting there, and 10, 15 minutes went by, and we were in the same room with the person that was our IRB representative, and she said, well, gee, I'm not really sure where the nurses are. And we were thinking, oh my goodness, how are we going to tell anybody that we got here and no one came? But indeed, after 15 minutes, they started to come. What they were doing was organizing themselves. So they were trying to make sure that all the patients were covered. They went through the tests that needed to be done. She said everybody wanted to come. That was the problem. And so they were coming in shifts to see us because that was how important it was to them. I have to say that it was very touching, and it was very revealing about how caregiving the nurses were and how important they really felt the environment was to helping them in their day-to-day work.
Great. Okay. Looking again at some of the other findings that you got, you looked again at a lot of different things in a lot of detail. And again, in the time we have, we can't go into those in tremendous detail. But in the limited time we have, one of the things that really struck me was a couple of the findings that really stood out. I just want to focus on those for a few minutes. And two of these were, first, that there were no significant differences found in the amount of time spent in direct patient care between centralized and decentralized units. Again, often one of the rationales for decentralized units is that it will increase the amount of time spent at the bedside by the nurse. Your study did not find that. There were no statistically significant differences found. That's one, I think, very important finding. And the second was that nurses spent more time interacting with medical staff in decentralized units. So you had two very critical findings relating to critical rationale for doing a decentralized nursing unit. Did either of those findings surprise you? Were they what you expected?
Well, I would have to say that most of the findings that we uncovered were really surprising for us. I don't think there was much that we were really sure what to expect. But I would say, even though there was no significance between the direct patient care in the decentralized or centralized, that might actually be due to IT and technology. In other words, I'm not sure EMR was rolled out on all of the units, and it's certainly electronic medical records was not in every place, in every facility at the time. So that would make sense that the nurses were not able to perhaps be as decentralized and stay as close to their patients as they would now today. So if you did the study today, it might be different. But I also would say that our study, from the numbers perspective of how much time the nurses actually spent, again, in the patient room, not necessarily, we don't really know what they were doing, but we're assuming patient care, that is consistent with the numbers that have been done in all the other studies. So nurses are not spending a whole lot of their time not being able to be at the bedside because they're so busy doing other, what we'll call non-value-added time, like answering phones, directing visitors on a unit, all kinds of things that do not allow them to be able to be providing direct patient care.
Yeah. No, I think the explanation of that makes a lot of sense, and it's important. But again, what it also says, at least from my perspective, is that just providing decentralized units is not going to overcome that by itself. And that, again, we need to look at a whole system as it affects the behavior, which includes, as you were saying, culture, technology, even the demographics of the nurses, as well as the design. It's not, the design can't do it by itself. Let's move on to, again, as you mentioned earlier, and you clearly become very animated when you talk about the focus groups and the participation. I think, at least my sense, Terry, is that in those sessions, you know, it was just personally rewarding for you, as well as just professionally insightful. You found the contact with the people terrific, and just something that brought to life what was going on in that situation. Looking at the slide that's up now, could you talk a little bit about what you found in more detail in the focus groups? You found, again, basically these 4 overarching themes and some design implications that gleaned from them. Could you just talk a little bit about those themes?
Yep. The themes that we ended up looking at for the focus groups were also, interestingly enough, articulated very well at times in the open-ended questions that we asked in the survey. Even though we were not able to use the survey data per se, we were able to look at the open-ended questions, and they responded to the focus group themes that came up as well. But we really found 4 themes: providing nurse-specific support. That means areas and places where nurses can actually do what they need to do, like charting, to help maintain a nurse's sense of control. It was very interesting that the notion of control in nurse stations and safety even came up as an issue, particularly on a decentralized unit. I thought that was very interesting. And then acknowledging nurses' professional privacy needs, so that they need also at times, they need a back door, they need a backstage, and then enabling nurses to stay separated yet connected. And talk a little bit about that. The nurses really were wanting to be able to be seen and available to their patients and their families. They thought it was really wonderful when they were in a particularly decentralized area that they were able to provide, they felt, more education, because they were able to capture family members more readily as they were coming and going from a room. But they also really struggled with this need to have a back door or a backstaging area so that they could get their work done, because they were constantly being interrupted and constantly being pulled in different directions. And I think this is interesting for us as we think more about and think about design and the concept of decentralized versus centralized. We have to remember something, that nursing is really a relationship-based profession. And that profession often extends beyond the relationship that they have developed with their patient and and the family that surround that patient. But it's really a relationship-based profession that is nurse to nurse as well. And we found them talking about that relationship being really critical to their well-being, their own well-being. They talked about needing places to meet and to mentor each other, to share thoughts about patient care, to have ideas about caregiving, and really to provide each other a sense of connection that is so important to help manage their stress levels when they're in stressful situations at work. And we had a wonderful series of focus groups. One of the groups that we met with were oncology nurses, and they had just had a recent redesign from centralized to decentralized, and they were telling us their experiences about being closer to the patient, which was wonderful for them. They really liked it. They kept talking about but they needed the architect at the time to build this room for this purple table. They called it the purple table room. And at some point, we had to stop them and ask them, what is the purple table? And they said to us, oh, well, we've had that forever on the unit, and it used to be in our centralized station. And what it is whenever there's a patient that's going to not need therapy anymore or not come here has been cured, we celebrate. That's where we have a celebration at the purple table. Whenever we're celebrating a birthday party with some of our patients and their families, we celebrate at the purple table. And also, they said when we're grieving a patient. So that spoke to us about the culture of nurses and really needing to explore that with the nurses as you're designing for them, because that was such a strong need for that group of nurses. It was imperative that it become part of the design dialogue.
Okay, great. I know we're getting close to the end and we're starting to get questions, so let's just move on and go to, again, some of the conclusions, which again I think are fairly clear from what you've been saying, and they're shown on the slide that's showing now. Basically, I think that the issue that we need to face at this point and address, I shouldn't say face, I should say address, are the limitations of the study. We've been talking about the things that you found, the insights that you've gained, and so on. But clearly, in any study, there are limitations. So let's just talk about those briefly, and then we're going to open it up for some questions. And again, it's true in any study. Time, resource accessibility leads you to do certain things and not to be able to do others. We've tried to collect some of the kinds of issues that, as a researcher, we would raise in looking at your study. One of the key ones, of course, is that the variability in the units called decentralized and centralized is quite significant. So it's difficult to say, well, in decentralized, X happens, in centralized, Y happens, because they're not the same kind of centralized, the issue we were raising earlier. And there's also, it's clear that you focused on certain kind of issues, time and activity patterns and so on, nurses' perceptions and their sense of what an ideal environment would be. You didn't collect data on medical outcomes or other kinds of organizational outcomes or patient satisfaction. Not a lot of data really at all on the patient side, on the doctor side, on family side. And so those are just facts. And it doesn't mean that the data you collected is not valid. It just means that there are things that were not able to be collected that would provide, again, further insight into the project that you're doing. From your perspective, which are the limitations of your study do you think would be most important for people planning a future EBD study to try to take into consideration to either reduce or to control or at least to take into account?
Well, I think you're correct. We did not take a systematic approach to looking at the nurse station from more of a holistic perspective. In other words, looking at it from all of the different, if you will call it, players that occur on the unit. But rather, we did want to we did want to really deep dive into what the nurses, the impact of the nurses. Our central question was, what is the impact of decentralized nursing on nurse work environment fit and their perception of their work environment fit. And so I think for future studies, if I could say one or two things, it would definitely be that you have to really be careful and understand what your research question is. Once you understand what your research question is, then you can better find the methods and the ways in which you can get at that question, whether or not you can develop hypotheses to then do some more cause and effect, causal relationships, which is not what we did. We did an exploratory study. So for us, it was really going back to the research questions that we had originally started with.
Okay, that's great.
You'd always do things differently, I suppose.
Oh yeah, no, there's no question about that. Let's go again. We can, we've talked about the limitations, and I think you discussed a lot of the things that we brought up in the discussion. And I think we should get to the questions. That's why people participate. Let's take the first question. It's from Lisa Platt, and she's asking, was there a manifestation of themes that were gathered during the qualitative data and of the decentralized unit? And if you could just respond to that, that would be great.
Yes, I think the question was about the nurses feeling isolated from each other or from their peers. And that was definitely true that nurses, when they worked in a decentralized unit, that they described, not all of them, but a lot of them did describe feeling isolated. And again, I just want to say that technology can help overcome this. Again, our study done 7 years ago, Voicero, which has probably been around for some time prior to that, but was not very common in our industry. So, and other ways of communication with each other. So nurses were worried. They sometimes felt worried about being so close to patients and families, particularly some families who had sometimes difficulty with diagnoses. It was hard for them to not feel isolated.
Great. We have another question from Melissa Pietkowski. And she's asking what some of your theories are about why the decentralized stations resulted in more interaction with medical staff.
Well, I think I have to draw on my nursing background for that. I think it's because the nurses happen to be closer to the patients in the bedside. Sometimes physicians, and this is not true of all physicians, but it's true of some of the units that I've worked on and some of the discussions I've had with nurses, the physicians don't necessarily announce that they're on a unit, and they just go in to see their patient, write orders, and leave, because they're busy as well. And I think because of the decentralized nursing, that the nurses near the patient, they are more able to see the physician when they're in there with them. Okay,
great. Thanks, by the way, for sending in your questions. This is great. This is the whole idea of the session. We have another one from Bill Huck asking about paper administration was a highly observed behavior in the study. And he's asking with the recent push to implement EMR across the care setting, how that's affecting what you're observing.
Our observations of the interaction between the nurses and the computers at that time, I have to tell you, the researcher observed much stress relative to that. There was a lot of difficulty with nurses being able to bring records up at the time, and even with the fit between that system and, say, an X-ray viewing system. And so the researchers spoke a lot about the difficulty that the nurses had, that it actually added to their stress. I think those things, a lot of that has been overcome, not all of it, and so I would imagine that if we did it again, we wouldn't see that as much.
Okay, great. Another question from Compton. Really, I think, I suspect an architect or designer asking whether there were some particular architectural features or characteristics of the building that contributed to your findings. And he's asking, for example, the size of glass in the doors or windows in rooms from decentralized stations, these kind of more detailed design features. Could you talk a little bit about what you might have found?
Yeah, we really didn't find anything significant at the time. The most pieces of, remember again, units that were not built recently, but most of the observations were the glass that was in a glass door actually looking into a patient room. I don't believe that any of the units, or maybe one of them had an alcove with glass, but it was really, really through the glass in the door that patients were being observed in the visibility. So I think as the design is evolving and as the notion of what decentralized stations are, that we would find that different today. And I think also we would find that there will be also, it will not necessarily be completely accepted because there's a privacy issue that gets brought up as well in terms of the patient being able to have complete privacy. Neither is bad or good, it's just a comment.
Okay, great, thanks. Heather Fenneman asked whether you had any contact with people from the Palermo Hospital. She's noting that they just built a replacement hospital and they claim to have no central nurses stations at all. What's your thought about that as a design approach?
Well, I have not had any feedback or conversations, although I'm well aware of the hospital, of course. But my comment would be that I think it could work. I think what we have to concentrate on now, not our nurse stations, but our team stations, because I think now that as we move the care and the dialogue even to the bedside with patient and family-centered care, that what happens is we still need areas for groups to come together, teams to come together, even nurses to come together at times to talk about patient care and patient care delivery. But I think the nurse station might be a thing of the past.
Well, just a comment maybe to my own research. We published relatively recently an article in the HERD journal that we did at a hospital in New Jersey looking at centralized and more decentralized units. And we've done a variety of projects over the last 7 or 8 years looking at those issues. One of the things that we found, which in part conforms, I think, to what you're saying, Terry, is that even when you provide decentralized nursing units of whatever sort those are, nurses create a hub. They come back and they're going to find a place where they can interact. And it doesn't seem to make a difference whether or not you have electronic medical records or it's technically feasible to get information from a decentralized unit. It's part of the relationship issue that you mentioned earlier, which I think is absolutely critical. And it's also part of a mentoring issue and an assistance issue that people, nurses, need to be able to help each other, ask questions of each other, and so on. And so even when they're using some of the decentralized forms of units, they're creating a centralized one at some place. And so I think it's one of your conclusions, I think, which we'll get to also, that you're looking for a hybrid model, I think, rather than looking for it's one or it's the other, and that anyone by themselves will solve the problem physically. And as we've already discussed, on top of that, you have technology, culture, demographics, management styles, and so on. And I would argue myself from our own research, and I think you've mentioned this also earlier, Terry, is that what's missing in much of the research is a kind of systems perspective where we absolutely look at these in a formal way as part of our research rather than relying only on one or two types of methods. Few points that I made.
You meant it's a hybrid comment?
Yeah,
Yeah, I do. You know, nurses and teams need to come together because they need to find ways to enhance and increase patient care. They will find a way. I mean, we did another study with the University of Kentucky not too long ago, and one of the observations was that the staff would found a corridor that no one else used because they didn't have a station to go to or a room that was designed specifically for a team station per se. And so they will find it. You just, you have to create it for them. And in the end, they did do that, and it resolved itself. But staff will find ways to do their work. Their work is situational. A lot of medical work is situational. In other words, it's not planned and prepared ahead of time. A lot of the work happens at the moment. And so it's very hard for them to then say, well, we've got to go down to the conference room on the 3rd floor to talk about this crisis that's happening, or they have to deal with a family immediately. You need that flexibility built into the unit.
Right. We also have a new question from Sue Nolenchuk. I apologize for probably pronouncing it wrong. And she's asking whether you thought the type of the nursing care provided made a difference in terms of the isolation factors.
Yeah, I would imagine that it's probably, Sue, that it's a few things. I do believe that it's the type of nursing care that you're providing, but you're always going to have, in any unit, as you probably know, you're always going to have some patients that may have some difficulties or difficult families. So I think just thinking about those things and thinking about what, the range of activities or the range of issues that can go on in the unit and just preparing for that. But I really do feel with the IT availability these days that wouldn't be so much of a factor.
Right. And just to add briefly my own sense about that, because I think it's a very important question about whether the solutions you provide need to vary based upon the kind of unit it is and the kind of care provided. But my own sense is that in certain kinds of units, like pediatric oncology, which is incredibly stressful and emotionally difficult for everyone, that, again, the need to come together for nurses to support each other would be particularly important, for example, compared to maybe a basic med-surg unit and other kinds. So that's something that, again, hasn't been looked at in great detail in the research, I think, which is relating the kind of findings we are observing and learning to the particular kind of unit is a very, very important kind of issue, whether or not it works for a NICU, whether it works for a pediatric ER. What are the different issues are very, very important. Again, one question, again, from Donald Lawrence, thank you very much, is do you have any recommendations, Terry, based upon your study on developing hybrid decentralized concepts, what that might look like?
Well, Donald, thanks for the question. I think I even have a slide to support that. Frank, can you get to the slide? Could somebody move to the slide with drawings? So we did
this one.
Thank you, and added a sort of an unusual element to our study. We did drawings with the nurses. Drawings have been used in research with children for many years, and so we decided to ask the nurses if they could tell us what an ideal nursing unit would look like. And in essence, of course, this isn't complete. This is just, a certain scope of nurses at a certain time. It would not be statistically significant, in other words, but it's very telling that 98% of the nurses drew the exact same thing in some sketch or rather. And what they told us was that what they really wanted on a unit was a separate reception desk adjacent to a nurse station so that they would have a buffer zone so that when people were coming onto the unit, whoever that was, family, patients, staff looking for them, that there was somebody that could address that first so they weren't constantly taken away from their work. And it was interesting. They saw the need, all of the nurses, for both a centralized concept where you had more of your sicker patients around a core where you would have nurse stations there that have this direct visibility into the more higher acuity patients. And then along the ends of the unit, where the patient rooms might be more quieter, there would be more decentralization and more, that need would be more of the nurse interacting for education and getting patients ready to go home. Now, this doesn't speak to a lot of different issues that could happen in nursing, such as acuity adaptable patient rooms. But as a concept, this was what they told us. And remember, 7 years ago, they told us, gee, one supply location just does not seem to work. And now, of course, that's being wrapped into the concept of what decentralized nursing really means, which is really being closer to your supplies as well as your patients, so you have less deaths in a day. So they were very insightful, and they were able to express in drawing as well as verbally what they really wanted to provide better care.
Okay, thank you. Well, I think we're just about coming up to the end of the session. Terry, I want to thank you very, very much for taking the time and coming and answering the questions, describing your study. I think it brings it to life in a way that it could never be done just in reading your article, which by definition you sort of eliminate lots of the context, and you provided that context. I want to thank you very much for that. I hope for all of you who've been participating that you found it useful. Again, both looking at how the research is done, why it's done, the rationale for what is done and some of the limitations that result from that, but also the fact that you can still draw some kinds of insights and conclusions to help you make more informed